Again, my name is John Hisamoto. I'm a physical therapist and athletic trainer with Advanced Rehabilitation Proactive Physical Therapy in Tampa, Florida. And our discussion today is really about the rehabilitation of the pre-post hip and knee surgery patient. I'm not going to get into the very basics. We're all professionals. I know that you know what you're doing, but what I do want to share with you is some information that I think will help you with some of the patients that you're seeing from both an evaluation and a treatment standpoint. And again, coming back to sometimes what makes sense to us from a rehabilitation standpoint. So let's look at a very slow down position associated with an upright position. So pole position should be vertical. That's what we're really looking for. Elbows are close to 90 degrees. Pressure is going down in that position. They're holding it fairly tight. So right foot, left pole is striking together as they kind of walk through and ambulate in those positions. We want them to have a very functional position and not to deviate through their pelvis or trunk, one side or the other. More of an upright position, pole position vertical, elbows are very close to 90 degrees. As soon as we go to poles, that increases that rectus abdominis, transverse abdominis effect and increases intra-abdominal pressure. So we're activating abdominals and we're inhibiting some of our thoracolumbar extensors so that this functional aspect that normally occurs with muscle imbalance is actually improved almost immediately by just initiating ambulation with those poles. So again, balance to me becomes one of the areas that we have to pay attention to. And I utilize my poles with my patients early on to create some clinical examples of how we want to progress balance training. So we always start in a static position, meaning that we want to control our center of mass relative to our base of support under unperturbed conditions. And that sometimes is just a simple little weight shift that we're going to be doing. So we're trying to get into activating those ankle strategies without pulling in the hip or the steppage gait. Then we'll go into more reactive type of movements, our ability to recover postural control after unexpected perturbation. So we'll kind of go into different floor surfaces, softer surfaces, harder surfaces, sand versus cement. And then finally, we'll go into proactive or anticipatory. And that's our ability to modify postural control prior to a potentially destabilizing movement in order to avoid instability. If you're a hiker or a backpacker and you're going down a rocky incline that might have a little soft rock or rocks might be moving, you're really paying attention to those destabilizing movements. But how about some of our older patients, especially when they're going down steps and they're having problems? That's when we really need to make sure that we're controlling that postural defect to make sure that we don't have a destabilizing movement.